Good afternoon, ladies and gentlemen. My name is Nirav Shah, and I'm the director of the State of Maine's Center for Disease Control and Prevention. I'm here with you today to provide an update on the COVID-19 situation across the state of Maine. And as we have for several days now, we begin today's update on a sad note. Maine CDC is reporting 3 additional individuals with COVID-19 who have passed away. One was a woman in her 70s from Cumberland County. Another was a man in his 80s from Waldo County. And the third was a woman also in her 70s and also from Waldo County. These 3 additional deaths bring the total number of individuals in Maine who have passed away now to 39. And I think it's important that we pause for a moment to reflect, as well as remember that each and every one of these data points that we talk about is in fact a person. And each figure was someone's family member. And that all of the statistics are in fact someone's spouse or sibling. So we here at the state of Maine continue to offer our condolences to these 3 families, as well as the 36 other families across the state, as well as the tens of thousands of families across the United States as they grieve the loss of their loved ones. Overall, the state of Maine is now recording 907 cases of coronavirus, an increase of 19 cases since yesterday. There are also 145 individuals who have been hospitalized at some point during the course of their illness, an increase of 5. Overall, 455 individuals have recovered, an increase of 12 since yesterday. Maine CDC epidemiologists have continued to study the patterns of disease spread across the state, and at this time, we have not detected any additional counties where community transmission has been found. And as of this morning, there have been a total of 16,784 negative tests on individuals in Maine for coronavirus. Again, that number is 16,784 negative tests. Overall, 222 healthcare workers are part of our 907 cases overall. I'd like to provide a quick update on some of the numbers associated with outbreaks of COVID-19 that Maine CDC has been working on with our partners at long-term care facilities and assisted living facilities across the state. At the Augusta Rehab facility here in Augusta, there is now an additional staff member who has tested positive for COVID-19, bringing the number of staff to 27 and the total cases affiliated with that institution to 74. At the Falmouth community, there is also an additional staff member, bringing again the total number of staff there to 8 and the total number of cases to 15. At the Maine Veterans Home in Scarborough, there remain 30 residents and 17 staff members who have tested positive. In addition, there's also one additional individual who has passed away at the Maine Veterans Home in Scarborough, bringing the total number of individuals who have passed away there to 5, and the total number of cases at the Maine Veterans Home to 47. At the Tall Pines facility in Waldo County, there's been 1 additional resident who has tested positive for a total of 30, and sadly 2 additional individuals who have passed away for a total of 10, and a total number of cases of 40. At the Cedars facility in Portland, there's also an additional staff member, bringing that total to 4, and the total number of cases to 11. Yesterday, Maine CDC became aware of an outbreak at a long-term care facility called Edgewood in Farmington, And at present, Maine CDC is aware of 2 cases among residents, one case among a staff member. As has been our protocol, as soon as Maine CDC became aware, we immediately shipped a series of testing kit materials so that individual residents and staff members could be swabbed. Those swabs rather, are being sent right now to our laboratory here in Augusta, and we hope to have test results as soon as possible on the residents and staff who accepted testing at the Edgewood facility. And finally, although it is not a long-term care or assisted living facility, we are also aware of 3 cases of COVID-19 associated with the John Murphy homes in Auburn, 1 among residents and 2 among staff. Based on what we know right now, none of those individuals is a youth. Again, based on our preliminary reports and investigation, the cases are among adult members of the John Murphy home community in Auburn, but more investigation is underway, and we are also proceeding with testing individuals and staff members associated with that facility. Overall, between long-term care and assisted living facilities in Maine, there are 123 residents, an increase of 3, and 67 staff members, an increase of 4, for a total of 190 individuals statewide. In terms of the critical assets that Maine CDC tracks, there remain a total of 314 ICU beds, 170 of which remain available across the state. There also remain 333 ventilators, 277 of which are available. On top of that, there remain available 367 alternative ventilators. At present, 18 individuals in Maine are reported to be in intensive care units because of their COVID-19, and 24 individuals are reported by hospitals to be in non-intensive care unit beds. And overall, across the state, 10 patients remain on mechanical ventilators because of their COVID-19. I'd like to take a moment now to talk a bit about the work that we've been doing around distribution of PPE. For several weeks now, we've talked about PPE, we've talked about who it's going to, who requests it, the ways in which it's been used, and the shortages that have affected not just the state of Maine, but the entire country. I'd like to take a step back from those discussions and talk a bit more globally about the amount and the volume of PPE that the state of Maine and our partners have distributed since we began our activation. So since approximately March 8th, Maine CDC, working with our partners, who I'll want to turn back to in just a moment, but since March 8th, Maine CDC has delivered 71,002 N95 masks, 194,305 surgical masks, 43,485 face shields, 215,847 gloves, 21,384 disposable protective suits, 5,138 shoe covers, 42,214 surgical gowns, and just about 600 boxes of hand sanitizing gel. That amounts to just under 600,000 pieces of PPE that have been distributed across the state. To put that number in context, I asked my team to do the math on what that actually looks like. That is the equivalent of 6 tractor trailers filled of PPE that the state of Maine and our partners have distributed to healthcare workers, fire and EMS, hospitals, and everyone on the front line over the past 6 weeks. Again, that's about 6 tractor trailers full of PPE. Now, we didn't do this alone. There's a large team of people that have been working days, nights, weekends, and holidays to keep that PPE going. Again, it's on the order of 20,000 pieces per day, 100,000 pieces per week that are going out. And that team is comprised principally of the staff at the Maine CDC in our Public Health Emergency Preparedness Program. They've been the ones quarterbacking the intake of PPE as it's been delivered by the Strategic National Stockpile, the orders that come in and the requests from healthcare facilities across the state, and the major logistics challenge of getting it all out within 24 or 48 hours. And so I'd like to just take a moment to thank the team in the Public Health Emergency Preparedness Program for everything that they've been doing. Now, they haven't been doing this alone. We've had immense and wonderful partnership with our colleagues in warehouses and logistics, with our colleagues at the National Guard, and with our colleagues at the Department of Transportation. They're the ones who have helped us load this PPE and ship it out and deliver it. The bottom line here, folks, is that this effort, as it's been going on for the past 6 weeks, has involved delivering PPE for Maine people, and it's been done by Maine people. This PPE, this 600,000 pieces that we've delivered, has gone to your neighbors, people in your towns and communities who use it every single day to keep themselves safe, to keep their patients safe, and to enable them to continue showing up on the job every day. And it's been delivered by those same people, by your friends, by your neighbors, people that you know who might be in the National Guard doing their service, people who you know who may work in state government, people who you may know who work in logistics at warehouses. This effort really has been a community-led effort, and it's been done for Maine people, for the benefit of Maine people. And I'd just like to take a second to acknowledge them and to thank them for helping keep that delivery of PPE going. Overall, accounting for orders that went out today, that system that we have in place to intake PPE, to receive requests, and then ship it out on a logistics manner, we've satisfied requests for over 1,120 institutions across the state. Many of those institutions have needed and have received multiple deliveries. And as we continue with our activation, we will continue to try to make sure that each and every healthcare worker has what they need in order to keep caring for people in Maine and keep showing up on the job every single day. So with that, I'm going to turn to our colleagues in the media. We've got a full roster today of 17 folks, so we're going to try to get through each and every one of these questions. And today's first question goes to Dustin from the New England Cable News Network. Go ahead, Dustin.
Hi, Dr. Shah. This is a layered question. Is there a specific numeric threshold of testing, contact tracing, or other method of monitoring that needs to be reached in regions of Maine, Maine as a whole, or New England, that has to be reached before we can begin initial phases of the White House or any other plan to reopen the economy or loosen some restrictions? What is that threshold? What do we need to get to on, and what might the obstacles be?
Great. So Dustin's question is about the amount of testing that we might need in order to get to some phases of reopening, or the so-called gating criteria. And Dustin, it's a great question. Again, it's one we think about quite a lot. And for us, it's less about a raw number of tests and much more about the threshold or the rate of tests that are positive. The reason I say that is because the rate of positivity tells us, as a general matter, whether too many tests are being done, or in most cases in the country, whether too few tests are being done. Imagine a world in which every single person that a doctor required a test on tested positive, 100% positivity. The implication of that from a public health perspective is that we're not testing enough people. A certain number of people you test should be coming back negative, so you know you're casting a wide net. Right now, Maine's rate of positivity stands at about 5%, which is significantly lower than what it is in many other states and in line with what it's been in other countries. Now, to be clear, this is one of those situations where lower is better, because it means that healthcare providers are casting a broad net in terms of who they are offering testing to. But we also know that we still need to expand our number of testing capacity. So, Dustin, what we're working on right now is not focused so much on how many tests are being done, but rather focusing on how many more tests would we have the capacity to do. Our goal is to make it such that each and every healthcare provider in Maine can offer a test to any of his or her patients without fear that the test might get rejected by a commercial laboratory or any laboratory because of resource constraints. So our goal is to equip every single healthcare provider with the ability, the capacity to do testing irrespective of any constraints on resources. And one of the ways that we look at that is our positivity rate, which right now stands and hovers at right around 5%. Far superior and far more equitable than what we've seen in some other states. I'd like to turn next to Mr. Fran Gonzalez from the Republican Journal. Go ahead, Fran.
Hi, Dr. Shah. Thank you for taking my call. I have two questions. The Maine Army National Guard brought in 4 troops on Monday to the Commons at Tall Pines and Belfast to help with cleaning and infection control. My question is, did this directive come from Governor Mills' office, the CDC, or did Tall Pines initiate this? And also, will we be seeing more Guardsmen troops sent to other facilities? And my second question is, what is the specific process or protocol for long-term care facilities to request PPEs to the CDC?
Great.
Thank you.
So Fran raises 2 questions. The first is about the role and the partnership that we have with the men and women who serve in the National Guard. And then the second question is about the process for PPE. And Fran, ever since we have been, again, starting our work, the National Guard has been active and involved and embedded with us here at MEMA on a day-to-day basis. Multiple times per day, we're interacting with them. Right now, as you noted, Fran, there are a few Guardsmen and women who have been deployed to the Tall Pines facility to help with cleaning and sanitation. The reason that's so important is that as folks at the Tall Pines facility move from one room to another, those rooms need to be cleaned and turned over so that other folks can be moved into them. In conversations that we have been having with the Tall Pines facility, last week they indicated that one of their top concerns was being able to turn over those rooms quickly. So essentially that sanitation, that vital environmental health function. So we touch base, as we do, with our colleagues to see what resources were available. The National Guard had individuals who were willing and able to be deployed to serve that role, and so that's how that's come to be. And by reports from Tall Pines, that relationship, that deployment has been very helpful for them. More generally, Fran, the procedure for any institution, whether that's healthcare or otherwise, to request assistance from the state, whether it's PPE or for environmental health services, is largely the same. That is to say, those institutions are asked to go first to their county emergency management agency to make that request. If the county is unable to fulfill that request, it then gets routed to the state here at MEMA, where it's reviewed by a team of folks at MEMA, and if it's public health related, with Maine CDC, and then we work to fulfill that request. The reason that's important is that the process for making those requests is one that's unchanged. It is consistent with other activations. This is one of those situations where, even though the virus that we are facing is new, the process that we go about facing it, the procedures that we have in place to tackle it, Those are the tried and true procedures that folks on the ground are aware of. We, again, didn't want to build a brand new ship and sail it at the same time. And that's why we've relied on the traditional incident command structure that's been in place and has been practiced by so many folks on the ground. I'd like to turn next to Amy Brown at WERU.
Thank you, Dr. Shah. Quickly, just first, would you mind repeating the numbers for Tall Pines today? The audio dropped from the call for just a second when you were giving those, I think.
Sure thing, Amy. There are 30 residents at Tall Pines who have tested positive. That's an increase of 1 since yesterday. 10 staff, which remains steady, and sadly, 2 additional individuals who have passed.
Okay, thank you. And can you weigh in on the U.S. CDC Director Robert Redfield's comments yesterday about preparing for things to get much worse this winter when we still have COVID and flu season starts?
Well, Director Redfield, so Amy asked about comments that the U.S. CDC Director, Dr. Robert Redfield, made with respect to the possible resurgence of COVID-19 in the winter. And Dr. Redfield in particular was concerned about the intersection or the co-occurrence of COVID-19 along with the flu season. Amy, and as everyone's aware, that's something that we ourselves were concerned with way back in January as we started working on COVID-19. That risk has a possibility of recurring come winter. So I don't disagree with Dr. Redfield there. But what I will tell you, Amy, is that the risk of resurgence that I'm looking at right now is not so much one in December, but it's one that could occur even more quickly this summer, depending on how the reopening process goes and the ways in which physical distancing measures may or may not be abided. So while I'm concerned about what might happen this winter, I'm keeping my eye a little bit closer, which is to say to the summer months. I'd like to turn next to Brad Rogers at WGME.
Thank you, Dr. Shah. The U.S. Senate just passed the Health Care Enhancement Act. It goes to the House now. Under that bill, Maine would get at least $16 million for COVID-19 testing. What would you do with that money, and is it meaningless unless the U.S. scales up production testing reagents and kits?
Great. So Brad's question is about legislation that's currently working its way through Congress. And Brad, I don't want to speculate because as everyone knows, the deal is not done until the deal is done and signatures have been applied and the money has been transferred. So that being said, based on what we know of that legislation right now, a certain fraction of it would be set for testing. And what we would want to spend that funding on would be at least three things. Three things that we know are essential for the testing to happen. The first is more equipment. Now, right now, we've been doing a lot of testing. All of our testing has been on the so-called PCR. That's the DNA RNA test. But we know there's another wave of testing coming down the horizon. The testing that's so-called the antibody testing that we've talked about. That antibody testing will require an investment. So that's one place that we may need to use that funding, is for antibody testing. The second piece, Brad, is for the reagents themselves, the chemicals, the ingredients that we use as we're baking that we know are essential for the final product. Ramping up production of those reagents, Brad, is critical. We understand that manufacturers are trying to do so, and they're trying to keep pace with the demand. But we are, again, in a situation where more is better. So we're looking for additional sources of reagent, and that would be an additional place where we would need funding. The third place that we would utilize that specific funding for testing would be on staff. We also need not just laboratory experts to run the DNA test, but we also need staff, like a medical transcription style staff, who can take the samples in, enter them into our computer system, and report the results out accurately and quickly back to the doctors who ordered them. So that's in general where we need to go with our testing and the ways in which we would use the funding. I'd like to turn next to Steve Betts at the Courier-Gazette.
Thank you, Dr. Shah. After this wave of the virus has passed, do you think as a society we need to rethink how we house our elderly? That's the question.
Yep. So Steve asks about once COVID-19 is to some extent in the rearview mirror, should we rethink the way that our parents, our spouses, our siblings, elderly among us, the way in which they're housed? And Steve, the answer there is, I think the answer is that I hope we do. Now, it may still be the case that nursing homes, long-term care facilities, as they are currently conceived, largely remain in the same form. But what I do hope this does is shine a spotlight on the ways in which individuals who are medically vulnerable, such as those who live in those facilities, are uniquely susceptible to infectious diseases. I also hope it shines a spotlight on the ways in which hospital-associated or healthcare-associated infections, how the burden of those infections can fall disproportionately on our parents, on our siblings, on our spouses that reside in those facilities. Steve, I can't speculate about what the structure of those systems may look like, but I do hope that we take certain elements into greater consideration, particularly around infection control and healthcare-associated infections. I'd like to turn next, you bet, Steve. I'd like to turn next to Dan Newman at the Maine Beacon.
Sure. Hi, Dr. Shah. There are a whole set of conspiracy theories spreading in Maine around the coronavirus, everything from it being homemade to a hoax to ineffectual home remedies. Does your office take any specific steps to track or address this kind of purposely spread misinformation?
So Dan's question is around folks who have alternative views on what might be driving coronavirus, as well as potential cures of it. And Dan, we do try to keep tabs on what we're seeing out there. The folks who run our various social media pages, as well as our communications team, frequently receive emails. And so we do have something of a sense, a bit of a temperature on where things stand. Here's what I'll say, Dan. We jump in the fray if we see information that we believe to be dangerous. To give you a very concrete example, an individual wrote me several weeks ago because this individual had read and believed that being in a very high temperature sauna for a prolonged period of time, on the order of about 140, 170 degrees, would cure what was ailing him. That's more than just misinformation. That's downright dangerous. And so the second I saw that email, I chimed in. There are others who have different views on the origins of coronavirus. And based on everything we know right now, the origins of coronavirus are consistent with what the scientific community has said. But, Dan, the bottom line here is that folks are looking for answers at a time when there aren't many answers. And as much as I always try to be straight with people, a lot of times that entails saying those three most difficult words for anybody to say, which is, I don't know. And oftentimes when people hear the phrase, I don't know, they will seek out security from someone who believes that they do know, even if what that person is saying is not grounded in good science. I think it's a good opportunity for me to remind folks that there are trusted, reputable sources of information out there. And if you have questions about the coronavirus, the first stop that I would ask you to go to are the web pages of the Maine CDC, the US CDC, or the World Health Organization. That information is scientifically grounded, and if they don't know something, if I don't know something, we'll tell you. But that's not a reason to go search for an answer from someone who may have a different agenda. So thanks for raising that question, Dan. I'd like to turn next to Steve Missler at Maine Public.
Thanks, Dr. Shah. Real quick, roughly how many tests is Maine CDC performing on a daily basis? And would you be willing to provide that data as part of your briefing or on the website going forward? And then I guess just a quick follow-up to a question I asked yesterday, and I was too slow on the draw to ask you it at the time. But you had mentioned the Abbott tests and the high rate, at least according to some studies, of false negatives, and you had said that the Maine CDC is asking providers to send in batches. Mm-hmm. What are you doing with that information? Are you finding new cases, and are they being added to the total, or are you just tracking to check the reliability of the Abbott test?
Great, good question, Steve. So as to the former, I don't have the daily number that our lab has conducted today or yesterday. The last time I looked at the numbers was on Sunday, and the average number of tests, literally the mathematical average, the mean, was on the order of about 100 per day. I think the median was a bit different. We'll get you the exact numbers, Steve. I want to be clear on one thing. Maine CDC's laboratory is but one of multiple laboratories now in the state that are offering testing. There are at least 5 commercial laboratories, the LabCorps, the Quests of the world, as well as at least 3 hospital-based laboratories, one affiliated with Maine Health, another affiliated with Northern Lights, and a third affiliated with I believe MDI, at least 3, and perhaps 1 or 2 more since Sunday. So Maine CDC's laboratory is not the only game in town, and I just want to emphasize there's a diverse portfolio. When we talk about testing capacity, we're not just talking about Maine CDC's lab, although that is a focus. We're talking about all of the capacity available in the state, such as the groups I mentioned. For the exact numbers that we are running on a day-to-day basis, we'll be in touch with you so you've got those precisely rather than my vague recollections from Sunday. And then in terms of your second question about the Abbott devices, you are correct, Steve. We continue to want to track the operational sensitivity of the machine in daily practice. Some of the studies that have been published or data that have been generated by other groups, one group in Chicago, another group in France. Steve, you mentioned the group in Cleveland yesterday. Those studies have been in somewhat ideal conditions. In fact, in some cases, very ideal conditions. What I mean by that, for example, is that the Chicago group looked only at hospitalized patients and had ENT surgeons drawing the swabs. We want to know in practice, what is the operational accuracy? So what we're doing with those samples that we get is running them through our gold standard machines at the laboratory here in Augusta to try to get a sense of what the concordance is. How well do the samples from the Abbott machine match up with what our gold standard machine says? That's just a scientific exercise. That's just good science. But if we do detect any positives, of course, we'll report those as well. So. And then again, we'll get you the exact numbers, Steve. Next, I'd like to turn to Eric Russell from the Press Herald.
Good afternoon, Dr. Shah. I appreciate your time. Is there any way for you to estimate, sort of the real number of cases given the testing shortage? Can you do any sampling? And are you still monitoring people who might have not been tested but are symptomatic?
Great. So Eric raises 2 questions. The first is there a way to estimate the total number of people in Maine who might have COVID-19? And then the second is, what do we do about folks who have all the signs and symptoms but haven't gotten a test? So as to the former, Eric, what we do as part of our modeling is that we use a range of estimates. Again, to go back to my tortured analogy with the iceberg, we built in our models different estimates of how much of the iceberg that we are seeing, ranging from 5% to 20%. And that gives us a sense of what the scope might be. And so again, if our 10% estimate turns out to be the correct one after all this is done, that suggests that there may be 10-fold more cases. We just don't know at this point. There have been some early studies that have tried to quantify that, and candidly, Eric, the results are all over the map. So that's why we don't pick a specific number. As we've talked about with all of our modeling, we're always using a different range of estimates. And then as we rerun the models, we rerun them with different estimates. What I will say, though, Eric, is that given our positivity rate, which is around 5%, that does give us some degree, albeit minor, but some degree of security that there's a decent amount of testing going on. Again, compared to other states and other cities where their positivity rates are 20+%, the fact that a lot of people are being tested, but not a lot of cases are being detected compared to other places tells us that testing is robust. Again, this is a situation where the lower the positivity rate, the better. Now, Eric, you asked a second question about individuals who have symptoms but aren't necessarily getting a test. Not too long ago, the National Association of Disease Detectives, that's not their official name, but their official name is CSTE, but I think of them as the National Association of Disease Detectives, published a definition for how states should start accounting for the exact type of person that you mentioned, Eric. So perhaps it's the spouse of somebody who has a diagnosed, confirmed COVID-19 case. And a couple of days later, that spouse starts showing symptoms. How we will start to track those folks. That's a pretty recent development that this organization just published, and we're operationalizing that, as are all the other 49 states right now, to help us get a better handle of that. Next question goes to Emily Tadlock at WABI.
Hi, thanks so much, Dr. Shah. My question today is, the White House has recommended that states reopen in 3 phases, and obviously this is going to require a lot of pre-planning. Where are you and the governor at with all of that, and is this something that individual municipalities or counties could help do?
So what I will say there, Emily, is that there have been very frequent, robust discussions across the administration with the governor and her staff, commissioners, the Maine CDC, and a variety of different stakeholders. I know that the governor has been thinking about this very intently and has been very focused on the ways that this can go about. My own view there, Emily, is that, and it's something I've said here, this will not be a decision so much as it will be a conversation. And I think it will be a conversation in which all types of stakeholders will be invited to the table, be they municipal leaders, county leaders, private sector leaders, and of course folks in healthcare and government. So I don't think any final decisions have been made, but I do know that very robust discussions have been had and are continue to being had. I'd like to turn next to Kit Harrison at Mjambo, Africa. Go ahead, Kit.
Hello, Dr. Shah. As we all know, this healthcare crisis is shining a very clear light on racial equity all across the country in relation to issues like poverty, education, access to information. I have a few questions related to this.
Sure.
Is the CDC collecting, the Maine CDC, collecting information on racial and ethnic breakdowns of COVID-19 infections and deaths in Maine? Assuming you are, is that information available, or at what point will you make it available? And finally, yesterday you announced a frontline warm line to manage the emotional toll the crisis is having on frontline workers. So a lot of those workers, as you know, are immigrants. And I just wondered if interpretation services are going to be available for those people who might need help.
Great. Thanks for those questions, Kit. So Kit asks about the toll that we have talked about at these meetings, the toll that COVID-19 has taken on all of us, and specifically on racial and ethnic minorities. Our focus, one of our touchstones in public health in general, is health equity. Not just during outbreak times, but also during non-outbreak times. And so, Kit, for that reason, we do ask individuals that our disease detectives interact with for their racial background. What we found, not just in this outbreak, but in a lot of outbreaks, is that folks don't always want to share their racial ethnic background with the health department when we call. But when they do, we definitely record that information. One of the things that we have to keep in mind, and we record it at a pretty granular level. It's not just general categories, but it's pretty specific categories. And we've been analyzing it. We've been taking a look at it. One of the things before we go forward with publishing it, which is most definitely our intent, is to put it on our website. I just want to be clear right up at the top. We absolutely want to and intend to put that information on our website. What we have to be careful about is making sure that we do not inadvertently disclose someone's identity. So if we happen to have a group that only has 1 or 2 people in it, and that group only has a few dozen people within the state of Maine within that group, if by putting that information on our website, we have to make sure we don't inadvertently disclose that someone has had COVID-19. So our team of epidemiologists has been working with our experts in privacy to try to make sure that when we put those data out there, we don't fall into that concern. But let me just be really clear, Kit, we have every intention of sharing those data once we've thought through that risk of inadvertently exposing somebody who is already potentially discriminated against, potentially marginalized. The last thing we want to do to them or to their own ethnic group is to put them under an even greater microscope. And then you asked about the frontline warm line and translation services. I'm going to triple check that, Kit, and make sure I get back to you. As a general matter, any service that we offer, we always try to make it as accessible as possible to all types, to anyone, whether they be from a different ethnic group or speak a different language. But as to exactly which languages are being offered, I'll make sure we get that to you. Kit, as I noted, is being staffed by volunteers, and so there may be an outside translation service that is involved, and so we'll make sure I get those details to you. I'd like to turn next to Kate Koff at the Ellsworth American.
Thanks, Dr. Shah. So I am wondering, this is a brief question, are there any plans to redirect healthcare personnel who have recovered from the virus and they have some immunity possibly into the highest risk situations? And I'm wondering if there are plans to do that, has that happened yet?
So Kate asks about whether individual healthcare workers, of whom we've got over 200 in Maine, whether after they've recovered, they could be deployed to high-risk settings. For example, although you didn't ask this, Kate, what's been on my mind is long-term care facilities, and whether individuals who have recovered could be part of the healthcare workforce at long-term care facilities. The answer, Kate, is that that's been something that's been under discussion. Our medical epidemiologists and I have been talking about this exact thing, whether they were recovered or perhaps in the final stages of being recovered. At what point could we safely have them back in the workforce, knowing that their risk of getting reinfected is low? It hasn't happened yet as a deliberate matter. Now, it's entirely plausible. The number I don't have right in front of me, Kate, is what percentage of those 222 healthcare workers have themselves recovered and are already back in the healthcare workforce. We've been tracking recoveries since day one. So it wouldn't surprise me to know that a sizable fraction of those 222 are already back in the healthcare workforce. That's not necessarily deliberate. That's just what it means to be recovered. It means you can safely re-enter the workforce. But Kate, your question was more specific about redeployment. Our medical epidemiology team has talked about just this idea of whether these recovered folks could be deployed into high-risk settings. We haven't had to do that yet, but depending on how the outbreak evolves, that's an option that we've got. It's something that we've started thinking about, but we have not yet done so deliberately. I'd like to turn next to Don Kerrigan at News Center. Go ahead, Don.
Yes, good afternoon, Dr. Shah. Thanks for taking my question. I have 3 questions relating to PPE. The first is, I believe yesterday you mentioned there were, I think, well over 100,000 of the N95 masks in your current inventory. Is that enough for a while? Second question, once you can, are you going to start stockpiling PPE of all types in preparation for a second wave, whether summer or next winter? And the third question about PPE, we've got people and businesses around the state who've been making various things, such as face shields. This ranges everything from people at home in their garage or basement to companies like Bath Iron Works and other fabrication businesses. Are those products actually getting deployed, getting used in the healthcare setting? If somebody makes a face shield on a 3D printer, whether in their basement or in a manufacturing plant, are those things actually getting used?
Great. Thanks for those questions, Don. The first is with respect to N95s. Just to give you the exact number, as of right now, as of this morning, our inventory of N95s is 179,750. As it turns out, 14,020 are being shipped out today. So tomorrow that number will be less, 14,020. Again, we're at 179 right now, and 14,000 N95 masks are going out just today alone. Just to harken back to my earlier theme, just a big thanks to the folks that are making all that happen. And so that's where we are on N95s. Your question is, where do we go from here? And initially, we were told that we would not be receiving additional PPE from the Strategic National Stockpile. Just about a week ago, we did receive 145,000 N95 masks. We're hoping that additional PPE remains and will continue to be forthcoming from the federal government, but hoping on the federal government to deliver N95s is not a strategy. So we are continuing our own procurement of PPE from private sector vendors as well as other sources. And that's our plan right now. Now, in terms of how long that might last us, Don, it's difficult to know. Depends on, again, what the complexion of the outbreak is. Don, you also then asked about stockpiling. Right now, we're not in stockpiling mode. Right now, we are in get it in and get it out mode. Deliveries get made, inventory comes in, orders get packed and pulled and shipped out immediately. We are not in the process of stockpiling at this time. That's something that we will look at more strategically once the outbreak shows signs of waning. That's the time at which we will start gradually building up our reserve. We do keep PPE on hand, but our goal right now is to get it in and get it out as quickly as possible. And then, Don, you asked about masks and face shields and other such pieces that are being made by manufacturing groups in Maine that have converted their production. I've read about a lot of those. I've got to say, each and every one of those stories I've read about, a father-daughter team that's now making face shields, each and every one of them brought a warm glow to my heart. We are trying to figure out ways to utilize that production. Right now, I think a lot of that use, Don, is being done and distribution is being done at the community level. So we're not necessarily accessioning it into our inventory. We deal usually in the hundreds of thousands. And so from my understanding, a lot of those productions that are occurring at the local level are going to folks in local communities as opposed to coming into our warehouse. And I just want to give a big thanks out to each and every one of those groups right now that's working on making that PPE at the local level and getting it to folks in their own neighborhoods and communities. Got a couple more questions. Next is Isha from the BDN. Go ahead, Isha.
Hi, good afternoon, Dr. Shah. I have two questions. My first one is about the IHME model, which was updated today to say that Maine can start relaxing social distancing rules by May 13th. Is this close to when the Maine CDC expects the state to start easing social distancing, and what factors will go into making that decision?
Great. Go ahead. And your second question?
Second question is, can you confirm that the use of critical care beds and ventilators in Maine hospitals is down across the state when compared to pre-pandemic times? And what, if that is true, what does it say about Maine's preparedness in response to coronavirus?
Great. So as to your second question, Isha, about critical care utilization, we'll try to get you a sense of what it has been during the pandemic as opposed to before. I don't have the pre-pandemic numbers here with me today, but we'll be able to get those to you in short order. In terms of the IHME model, as well as other models, as you've probably noted, even the IHME model has been changing itself pretty quickly. A couple of days ago, it had a different date. That's what models do. they change as new data come in. Our models, again, are trying to just help us get a sense of what factors we need to be thinking about for our own planning, and a little bit less about any potential forecast or prediction. What I will say is that it's less at this point about relying on a model. The modeling exercises initially that we've talked about were helping us to get a better sense of scenarios for resource utilization. Right now, what's driving our decisions and our thinking about any reopening is much less a model and much more the day-to-day figures and looking backward on things like moving averages over the past 14 days, as opposed to projections that are going forward. To put it more directly and succinctly, we're looking, as we think about the next 14 days, we're looking at what's going on today. Whereas previously, as we looked at the next 14 days, we were relying on projections. Right now, we're looking at what the virus is doing today as we think about where we need to go. And that's really the fundamental basis upon which we're thinking about this, as opposed to any types of projections by models themselves. I'd like to turn next to, go ahead.
Hi, is that because you're relying on the past 14 days, you're saying, is that because of the fact that there's now enough data to rely upon to base your own projections, as opposed to before when there was not enough data and projections were the best estimate? Yep,
so Isha's question is now whether the models are less valuable because we ourselves at the state level have more data. And actually, Isha, that's actually not the reason why. When we think about trajectory going forward, the best predictor of where things might go is not so much what a mathematical model tells us, it's just literally what has transpired. The IHME model is based almost directly on the experience with the virus in Wuhan, China. And it's just a scalar fit of that model to different states. And given now that we've had a fair amount of data that's been generated, as well as some trend lines, that gives us a more accurate representation of what might happen in Maine, rather than having to rely on the IHME model, which is still using data from the experience in Wuhan. So it really is more about localization and the data that we've got and the experience that we've had, as opposed to what might have happened a couple of months ago in another country. I'd like to turn next to Rachel Mann from ABC 7.
Thanks, Dr. Shah. Yesterday, you spoke a lot about how people shouldn't stop seeing their doctor for essential reasons. But for those without a primary care doctor who might be sick beyond a minor cold, but maybe not have COVID symptoms and are on the fence about seeking health care in these times, in what way should they seek a primary care doctor, or should they just go to urgent care and wait till this is over to find a primary care to not overload that system?
Great. So Rachel asks about ways in which people who might not have a primary care doctor could go about finding one. I actually got an email from somebody yesterday asking this almost identical question, Rachel. And what I responded was, one of the best places to start your search for a primary care doctor is with a federally qualified health center. Federally qualified health centers across the state specialize in primary care. That is their bread and butter. And we've been working with them throughout the coronavirus situation to make sure that they've got what they need to continue providing comprehensive primary care. So my recommendation to anybody out there who is seeking primary care assistance, maybe now is the time you'd like to establish care. A federally qualified health center is a great way to do so. I also want to just take a quick moment to acknowledge another individual who reached out to me who has been dealing with a chronic medical condition and had thought to actually hold off on going to get an injection that they were going to get or need to get, and decided after yesterday to go ahead and do so. And I want to thank that person for sending an email to somebody who sent it to me. I'm glad, I wish you all the best, and I'm glad you went that route. Really glad you went that route. I'd like to turn next to Mike Fern at the Maine Edge.
Thank you, Dr. Shah. I wanted to follow up on your figures regarding our healthcare workers. You said last week that healthcare worker infections were running around 21%, which fell in line with the nation's average of 20%. The 215 you figure that you gave us yesterday and today's 222 are actually running about 24.2% and 24.4% respectively, which is trending upward from last week. Do you think this ratio will continue to grow, especially in those congregate or long-term care settings? And if so, how concerning is that? And I have a quick follow-up about the antibody tests. Do you know if they're actually being shipped to the state first or to hospitals directly? And has that already begun?
So, Mike, let me start with your first question on healthcare workers. And as I've talked about during these meetings, in public health, as in life, when you go looking for things, you find them. And right now, because of our policy to recommend universal testing of all healthcare workers and residents when there are outbreaks in congregate settings, we know that we will detect additional cases, not just in residents, but in healthcare workers as well. So the fact that we are seeing an increase of healthcare workers, as you noted over the past several days, is not a surprise. It was anticipated, and by design, what we want. We want to be able to identify each and every healthcare worker, especially those in congregate settings, because of the frequent interactions they have with different patients. So this uptick is not a surprise, and it's one that we wanted to see because of our universal testing policy. Universal testing, again, means that every single person is offered a test. And when we offer every single person in a facility that we know coronavirus is circulating in, we're not surprised when we find additional cases. So this increase, not something that was surprising to us, and is part of what we knew to happen when we went down the road of universal testing. Whether it will continue to happen, Mike, I can't speculate, but it wouldn't be surprising, because when you go looking for things in public health, you do find them, and that's what we're doing right now in congregate care. We're actively looking for cases rather than just waiting for people to become symptomatic and potentially continue to spread it. Now, in terms of antibody testing right now is very much at the nascent phases. There are only 4 tests that the FDA has approved for antibody testing. Right now, we are approaching antibody testing with an eye toward it being part of our longer-term strategy. But to what extent any hospitals in Maine have had any of those tests delivered, that I don't have insight into. That would really be something for the individual hospitals to be able to provide more information on. And today's last question goes to Megan from WMTW. Megan from WMTW, your line's open. Megan, if you are...
I keep getting muted.
Oh, yeah.
Yes, I'm here. I'm sorry.
No, not at all.
I kept getting muted and unmuted and all muted nonsense. Anyway, my question is about the frontline warm line. It's been, or was launched about 24 hours ago, yesterday. I wondered if you had any kind of feedback, how well it was received, if you knew if people were actually taking advantage of it, and I guess just how it's been received in the last 24 hours.
That's a great question, Megan. Megan asks about what the first 24 hours experience with the frontline warm line has been. To recap, yesterday, the state of Maine, working with partners across the mental health, behavioral health, and social work community, launched a helpline, a warm line for healthcare workers, law enforcement, anyone who's working on the front line of COVID-19 to get help. The emotional toll of COVID-19 has been one that's been felt across society. And although we've talked a lot about patients, family members who are grieving, I think we all have to acknowledge that healthcare workers who are contending with this day in and day out are also feeling the grief. And that's why we launched this warm line, to give healthcare workers and frontline workers a safe space that they could call and get help and be connected with other healthcare and mental health professionals, behavioral health professionals. Megan, I don't have with me right now the data on what the first day's experience has been. I did hear purely anecdotally through, again, someone who emailed somebody who sent the note to me, that someone that they know had called yesterday because they had some difficult interactions and were trying to grapple with where to go next and how to seek help. And from what I understood from the message that was forwarded to me, the interaction was successful, but in terms of the data and what the first day's usage has been, we'll try to see if we can get a handle on that for you. But I do want to take a moment to note that if you are on the front lines, displaying that quiet, powerful heroism, that courage of knowing that you're taking a risk by going in every day, that possibility, knowing that you're doing so every day, is bound to take a toll. And so please know that if you are on the front lines and you don't feel like you can talk to your coworkers, you certainly can't talk to your patients about how you feel, know that there are other people in Maine who are behavioral health professionals who are standing by to help you. I do ask you and urge you to give them a call. They are standing by to help in every way possible. So thank you so much, everyone. I appreciate the questions today. I look forward to chatting with everyone very soon. Take care.